All right, continuing on then with module F5. We talked about the indications for artificial airway suctioning. Now we can move along. Let's see if this one works. No such luck. Okay. So some of the indications we talked about, presence of coarse sounds like coarse crackles. If they're on mechanical ventilation, we may see a higher peak inspiratory pressure in a volume-based breath or reduction in tidal volume in a pressure-controlled breath. Visible secretions in the airway. As we go along, we'll find that we can look at a graphical display and get some sort of idea what's going on. But basically, it's a patient who is not doing well. We also will do this artificial suctioning of the airway if we need to get a specimen. To need to maintain patency and integrity of the airway, stimulate a patient's cough, or when there's atelectasis to see if it's something that we can remove in that fashion. Suctioning of the artificial airway uses the same equipment we did previously, with the exception of maybe now something else to be able to access down into the airway itself. Now, because I have an artificial airway in place, I want to be able to use the correct size. And there's multiple different versions out there. The one we're going to use is the one in red there. It's take the inner diameter of the endotracheal or tracheostomy tube, multiply that times 3, and then divide by 2. So that'll tell us that we're basically occupying no more than 1/2 of the inner diameter of that artificial airway. We multiply by 3 to convert the millimeters of inner diameter to a French size, and then we divide by 2 to give us 1/2. So here's where we're looking at a endotracheal tube that has 8 inner diameter. We would take 8 times 3, 24 divided by 2 is 12. So we would use a 12 suction catheter. And just giving you some sort of idea, 4 millimeter tracheostomy tube, 4 times 3 is 12, divided by 2 is 6. For a 6, we would go with a 8 French. There, it calculates out to 9, but the French side catheters only come in even numbers, so it would go to the next smallest size. In the case of a 7.5, 7.5 times 3 divided by 2, 11.25, which again does not exist, so we would go with the size smaller. And with a 10 millimeter trach tube, we would use a 14. So what we're going to do is we're going to open suction, which means that that the suction catheter is disposed at the end of this process. We're going to pre-oxygenate with 100% oxygen, ideally using the ventilator or a resuscitation bag. We're going to monitor the patient's cardiovascular. We're going to go ahead then and set our appropriate suction levels, which we talked about earlier. We're going to gather our supplies like sterile water, our sterile kit. We're going to put on our sterile gloves in a sterile fashion. And then again, we'll have the one hand being sterile, one hand being non-sterile, attached to tubing. The presence of saline installation into an artificial airway is very controversial. You'll find people who swear by it and people who don't. I'll just leave it at that. If you do instill, we instill usually 3 mLs of normal saline directly into the endotracheal tube, and then we'll manually ventilate to distribute that and then suction the airway out. So again, we're holding the catheter by the tip. We're going to go ahead and pass the sterile catheter into the artificial airway without vacuum. If obstruction is meant, we can rotate it. Advance the catheter until we get a cough, then withdraw the catheter ever so slightly to prevent trauma, and then suction is applied for no more than 10 to 15 seconds as we're removing the catheter and rinsing it. For some patients, you need to use markings. So for instance, on infants or patients that have had a lobectomy, you don't want to put the full suction catheter in. We need to determine the proper length that is necessary and only be able to insert the catheter up to that point in time. Once the procedure is completed, we'll go ahead and post-oxygenate and suction out the mouth and nose, and then dispose of equipment properly, reassess the patient, remove the PPE, and go from there. Contraindications and complications to suctioning. There's no absolute contraindication to suctioning when an artificial airway is in place. It's a necessary procedure, in fact, because patients can't remove secretions because their airway is compromised by the endotracheal tube being there. There are some hazards and complications. Trauma, again, is one of the major ones. There's the mnemonic HAHA, hypoxemia, arrhythmias, hyper or hypotension, and atelectasis. And there's some other ones that you can see there on the right. Patient is suffering from hypoxemia, dysrhythmia, and bronchospasm during suctioning. What methods you would use to assess the patient's status during suctioning? So we would have some auscultation and probably a pulse oximeter as well as a ECG monitor. And we would make sure that we limit the amount of time that the catheter is in the airway and stress pre-oxygenation involved. So some of the things that we would be able to assess. And what precautions should be taken for hypoxemia. And we talked about pre and post oxygenation, limiting the amount of time you're in the airway. And as far as dysrhythmias, it's exactly the same thing, because the dysrhythmias are most likely caused by hypoxemia. With bronchospasm, again, make sure we're not going in too deep or inserting the catheter too aggressively. And these are the patients that probably should not have any installation down the endotracheal tube promoting that. Troubleshooting. No suction pressure generated from the system. Make sure everything is tight. And most often is the case where the collection bottle may have been emptied or thrown out and a new one is not sealed properly. Suction pressure is lost during suction catheter. Again, it's a connection issue. No suction pressure generated from the wall. Make sure that the system is operating properly and it's plugged in and it's set to the appropriate level. There also is two different settings on most regulators in the hospital. One is continuous and one is intermittent. We want to make sure it's set to continuous. You cannot advance catheter more than 5 inches. That could be a kinked endotracheal tube or the patient is biting, in which case we may need to use a bite block of some fashion. You hear a honking sound after suctioning. Could be a sign of a mucus plug or laryngospasm. Problems removing secretions. Again, we talked about possibly using a saline installation. Could need that you need a little bit of a larger catheter, making sure that it doesn't exceed at least 2/3 of the inner diameter. May need to use a higher suction pressure, but more often than not, it means changing to a better humidification or hydration system because the secretions are too viscous. Any adverse reactions, obviously stop immediately, oxygenate the patient, and in the future then use lower pressures and lower duration of suction being applied to minimize trauma. The process of collecting a specimen, this is the wrong way. And this is the wrong way. He loves sputum cultures. Odd way. We're going to use a Lucan's trap to be able to collect the specimen by placing the trap upright between the catheter and the suction tubing itself. So here, this one on the left is going to my vacuum source. The one on the right is going to the suction catheter, and this is spliced in between. This should be done prior to a closed suction system being instituted. So the first time we suction an endotracheal tube, we'll get a specimen using an open kit for the sampling. And once that is done, then we'll go ahead and place them on a closed suction system. Saline can be used for installation and catheter rinsing. Even if it's a cytology, just do not use hypo or hypertonic saline. Once the specimen is obtained, again, this is a biohazard, so you need to transport it to the lab in a biohazard bag, labeling it with the patient's name. If it's going to be a duration between the time that it's obtained and it's sampled, placing it on ice and transporting it to the lab, and we'll go through the practice on that one. And that concludes our process. Any questions? We will take them there.